vascular disease. Client presentation. So John is a 60-year-old male who self-presented to the vascular clinic with complaints of left leg calf pain. Upon subjective interview, John reports that he can walk for 100 meters before the onset of moderate left leg pain and is able to walk with pain for another 100 meters or so. The symptom is known as intermittent claudication, which is the major symptom of PVD and is characterized by a reproducible aching, cramping sensation or fatigue, usually affecting the muscles of the calf in one or both legs. Intermittent claudication is triggered by weight-bearing exercise, such as walking, and is often relieved with rest. PVD appears to be a secondary pathology from atherosclerosis, and this was confirmed with an ABI assessment. PVD occurs when arteries in the leg become narrowed or clogged, causing less blood flow. John has lived a sedentary lifestyle, and this is a significant risk factor for PVD because he has a history of smoking for 35 years and has type 2 diabetes. His risk of mortality is 2.5 times greater. Due to pain sustained during walking, John's exercise tolerance is very low. This has caused a lot of frustration and is a huge psychological barrier to ongoing exercise. To manage this psychological barrier, I have arranged for John to attend a weekly men's shed group in his local neighborhood to enhance social health and bond with other men. John has also been encouraged to join a coffee and walking social club. Interpretation of relevant results. John's ABI indicate PVD, right leg indicate asymptomatic or mild or moderate intermittent claudication, and his left leg indicates severe intermittent claudication. John is classified as stage 2B under the Fontaine classification of peripheral artery disease, as a disease distance to pain onset is less than 200 meters. His HbA1c is equal to 7%, which indicates a diagnosis of diabetes, as it is more than 6.5%. His blood pressure is 128 over 80 millimeters of mercury, and is classified as high and normal. His total cholesterol is high at 6.0 millimoles and should ideally be less than 4.0 millimoles. John's LDL is high at 3.1 millimoles per liter and should be lower than 2.0 millimoles per liter. His HDL is 0.6 millimoles per liter and should be higher than 1.0 millimoles per liter. His BMI is 28 and indicates that he is overweight. Exercise can be used to manage intermittent claudication and type 2 diabetes by increasing exercise tolerance. And exercise tolerance is the result of these proposed mechanisms. One, it increases leg blood flow due to capillary number and improved vasodilation. More efficient redistribution of blood flow, improvement in the efficiency of walking economy and oxygen uptake kinetics, increased strength, increased free living daily energy expenditure, high concentration of oxidative enzymes, blood glucose regulation. Additional assessments, other assessments I would add is the post-exercise ankle brachial index measurement. This post-exercise ABI value would indicate progression of PVD. For example, if the post-exercise ABI indicate a decrease of more than 0.15 over time, this may indicate a significant PVD progression. Another assessment I would add is the 6-minute walk test. If John's walking distance increases from 8 meters to 20 meters after adhering to the exercise program, this would indicate a minimum clinically important difference. Another test I would do is the grip strength. The rationale for that is to assess the static or isometric strength of gripping muscles. Treadmill walking performance, maximal treadmill walking time can be used using measuring the Gardner-Skinner protocol, and the MCID was defined as 121 seconds for patients with PAD. The rationale is to determine the time of onset of claudication pain and total walking time before and following therapeutic intervention, and to assess exercise limitation. The SF-36 is a generic outcome measure designed to examine a person's perceived health status or health-related quality of life. 30-second sit-to-stand is another test that I would do, and that is to evaluate lower limb strength and the ability to perform activities of daily living. the strategies used for monitoring performance during testing and exercise would be a heart rate monitor and accelerometer. Goal setting, practitioners' goals. To improve walking capacity, and this is increased time to claudication onset and maximal pain. Manage comorbidities like type 2 diabetes, reduce risk factors like sedentary lifestyle, improve muscular strength and minimize dystrophy, improve functional capacity and endurance, improve secondary prevention of cardiovascular disease. John's goals include the use of exercise to reduce pain when walking and reduce the need for lenses at night. Some considerations for exercise: a longer warm-up may be needed during colder months. This may aggravate claudication symptoms. Medication dose and timing should be considered before exercise. Cycling or other non-weight-bearing exercise modalities may be used as a warm-up, but should not be the primary type of activity, as walking is still considered the most important modality. Week 1, Session 1. The first clinic session is a 60-minute long session, and the goal of the session is to increase the time to onset of claudication pain by increasing walking distance. The EXSC and ACSM guidelines state that the aerobic session should last between 30 to 50 minutes. However, I've decided to take a conservative approach due to the cardiovascular risk factor and intermittent claudication, and start John with a 15-minute interval walking session. Session is split into a resistance exercise component and an aerobic component. The resistance exercise component is a whole body circuit-based pin-loaded resistance session which consists of 3 sets of 10 reps with a 2-minute interval between sets of the following exercises: chest press, leg extension, seated row, knee extension, arm curl, leg curl, frontal raise, and calf raise. Duration of the resistance exercise component was approximately 30 minutes. All exercise achieved a moderate intensity based on a rating of perceived exertion of 5 to 7 out of 10. In the 6th week, tests were performed to adjust the load progression. Additionally, load adjustment was carried out whenever necessary to keep exercise intensity within the limits established. A lower body focus was emphasized to minimize the effects of dystrophy and muscle weakness. The aerobic component consists of a supervised treadmill interval walking session with the aim of accumulating only 15 minutes with a 3x5 minute interval as the goal. The ACSM recommends that walking should be the primary mode of exercise for improving walking ability and claudication symptoms with an intensity that elicits moderate to strong claudication pain for a duration of 3 months. Involving at least 30 to 60-minute sessions per week would be beneficial. However, I've opted for a flexible and highly individualized session, as according to the assessments, John is able to walk a maximum of 200 meters with cramping pain, and that the optimal work to rest ratio has not been determined for individuals with PAD and may need to be adjusted for each individual. The Transatlantic Inter-Society Consensus Document of Management of Peripheral Arterial Disease 2 also recommend walking at an intensity that elicits moderate to maximal claudication pain. The plan over the next 6 weeks of the clinic session is to increase intermittent walking by 5 minutes every week in accordance with ACSM guidelines. A supervised treadmill exercise program has been considered superior to home-based exercise for patients with PAD. For example, Falkenrud et al. The meta-analyzed 14 randomized trials of 1,002 participants comparing supervised treadmill exercise with unsupervised exercise. Supervised treadmill exercise was associated with an 180 meter greater improvement in maximal treadmill walking distance than unsupervised exercise, although there were no differences in quality of life between the two groups. Week 6 of the clinic session should see John accumulate at least 45 minutes of the treadmill interval walking with an ideal 9 by 5 minute bout 3 days per week. The home-based exercise program included an interval walking program with a men's coffee group. John was advised to walk to the point of near maximum leg pain or claudication pain endpoint as recommended by EXSC guidelines. That is 4 to 5 on claudication pain scale. I chose to prescribe a high intensity session because a randomized control trial showed that the use of low intensity home-based walking exercise did not improve the walking performance in patients with PED, which showed no improvement in the 6-minute walk distance. A meta-analysis by Parmenter et al. 2015 investigated the relationship between exercise intensity, VO2 peak, and maximal walking distance, and demonstrated that the greatest improvements occurred when exercise intensity was between 70% and 90% heart rate max. That is vigorous intensity according to the American College of Sports Medicine guidelines. John was taught to use an accelerometer to monitor his walking exercise intensity. This was worn at the hips. The accelerometer counts corresponding to low and high intensity walking exercise were determined. Low intensity accelerometer counts were determined by having John wear the accelerometer while walking for 5 minutes comfortably without ischemic leg comfort. The training speed was converted into a walking cadence of steps per minute and paced at home by using a metronome. It was faster than John's walking speed at the clinic sessions and increased weekly. John was instructed to stop walking and rest when his claudication pain reached a moderate to strong level. When the claudication subsided, John was encouraged to resume walking until a moderate to strong claudication pain recurred. The individualized intensity accelerometer counts were benchmarks for low and high intensity exercise for John that guided exercise intensity monitoring. John was instructed to walk around the block 5 times per week for up to 45 minutes per session, wearing an accelerometer to document exercise intensity and time. He was encouraged to walk at a pace eliciting moderate to severe ischemic leg symptoms with the goal of having 9 stops as maximum rest intervals. After the session, he was instructed to upload accelerometer data on exercise frequency, time, and intensity onto the Exercise Diary app. I was able to view the data and telephone John weekly and help him adhere to the prescribed exercise. John was encouraged to record his exercise goals each week and write down the time he spent walking for exercise each day. He met quickly with other patients with PED, where success, challenges, and strategies to overcome barriers to exercise were discussed in a group setting. Because the client had access to a TheraBand and Swiss ball, the home-based resistance exercises were based using these 2 exercise equipment. Adverse event contingency plan. In the event of rapidly declining blood glucose levels, John was advised to always wear ID bracelet and have his mobile phone, carry glucose jelly bean, schedule exercise when BGL is naturally increasing, take carbohydrates 1 to 3 hours prior to exercise. Because John has displayed a poor understanding of his illness and the benefits of exercise like walking, I would provide education on secondary prevention of cardiovascular disease like smoking cessation, diet changes, lipid modification, statin therapy, antiplatelet therapy, and management of diabetes and hypertension. I would encourage him to increase his incidental activity by walking to the shopping center instead of catching the bus. To enhance exercise adherence, I would encourage John to participate in a group-mediated cognitive behavioral intervention, which requires weekly group meetings with other patients with PAD and a facilitator. Social cognitive behavioral change theory and group support can be used to help patients adhere to a home-based exercise. Group meetings included discussions regarding goal setting,